The purpose of the seminar was to increase your awareness of what's available out there in the world of surgical weight loss. Because we have seen many patients coming through with very good results, and we have seen many people turning their lives around. So we thought that this might also be a good avenue to actually reach people like yourself. And we believe that we can help you to achieve the same. One of the things that I just want to make clear from the start is that we at the Surgical Weightloss Centre, we recognize obesity as a disease. And for instance, we do not see somebody as being obese, but somebody as having the disease called obesity. And that's actually a very an important distinction in dealing with this whole thing. And we want you to be aware of the same, that it's actually a disease that you need to take control of, rather than to see it as part of who you are and what your identity is. And also, the other thing is, weight loss surgery is not a quick fix. And there's a lot of judgment out there about why people have weight problems, and people judge themselves and all that, but it's very complex. Just to illustrate the point also is that I've looked at the World Health Organization website, and at the moment, overweight and obesity would be the 5th largest sort of risk for global deaths, and that's huge. At least worldwide, at least 2.8 million adults would die each year due to, as a result of being overweight or obese. 44% of diabetics have issues with being overweight and obese. 23% of people who get ischemic heart disease actually have obesity, and it is implied in 7 to 41% of certain cancers. So we know that there are different ways to actually try and measure where the divide lies between being normal, being overweight, and having obesity. One of the ways of doing it is to use the body mass index, and there are several other ways. And the whole discussion that follows tonight is based on body mass index. It essentially sort of corrects the weight for height, so that one would always measure apples with apples. The definition of being overweight is if the body mass index is above 25. The normal range is said to be between 17 and 25, and obesity is set in, when we are dealing with a BMI above 30. So to discuss who would be a suitable candidate for surgery, we would normally rely on the body mass index, but we'll get to that again a bit later. The reality is that with all the technology and medication around and available in today's day and age, surgery is actually the only way to truly lose significant amounts of weight sustainably over the long term. There are many other sort of ways of losing weight around, and I know that I'm talking to a group of people who have probably been exposed to a lot of it, who have tried a lot of this, and who have only seen moderate or short, brief periods of success. But if we are talking about weight loss, we normally express it in terms of the percentage of excess weight. And excess weight is normally taken as that which is above a BMI of 25. Now, with the best lifestyle management programs, sustainably, patients would lose about 5% to maybe 10% of the excess weight. And surgery actually allows you to achieve 50 to 70%, which, as you can see, is a complete different ballpark figure. The different procedures that are available will also have different success rates, and gastric banding used to be quite a popular way of undergoing weight loss surgery in this part of the world. It is a little bit less popular at the moment. If one would be looking at large studies performed worldwide, the power of gastric banding is not as much as with, say, a sleeve gastrectomy or a gastric bypass. We would normally advise a procedure if somebody has a body mass index above 40. And the reason we say that is that there have been numerous studies worldwide when they compare the risk and benefit of surgery would actually show a clear benefit above a body mass index of 40. And that is regardless of whether one would have any of the obesity-related conditions such as diabetes. For patients who have a BMI above 35, between 35 and 40 with any of things such as diabetes or high blood pressure or sleep apnea, or if somebody has crippling osteoarthritis, one could then also expect benefit from surgery. And that leaves us with a group of patients between 30 and 35 where one would sort of individualize and sort of decide on a case-by-case basis about, you know, the true benefit that could be derived from surgery. And in this group, there would also be endoscopic procedures which are available, which I will demonstrate a bit later. So if we look at the types of procedures available, I'll just go straight through to the diagrams. The first is, and the one that's most popular at the moment, is a sleeve gastrectomy. With a sleeve gastrectomy, we essentially reduce the size of the stomach significantly. And in reducing the size to usually somewhere below 300 milliliters in capacity, the normal stomach holds about 1.5 liters. So we reduce it to a capacity of less than 300. It's usually only about 150 after surgery, and then gradually it stretches, so that about 18 months down the track it sits at about 300. But that is the first operation, that is the popular one at the moment. It doesn't only work by reducing the size of the stomach and the amount that a patient can actually eat. There are many other mechanisms, and one of them is a hormone which is produced by the stomach. And when an operation such as this one is performed, the levels drop and they stay low. And this hormone is called ghrelin. And high ghrelin levels normally lead to excessive hunger. So that's one of the other mechanisms of this operation. Another operation which we perform in selected cases is a gastric bypass procedure. It is mostly used for patients with severe reflux issues. And I'm talking about patients who, for instance, can't lie flat in their beds at night, who need to sleep in a reclining chair because of such bad reflux. And we can also sometimes use it very successfully for somebody with severe diabetes. But for the standard patient who comes through, one could argue that it's a big operation and that there are potential long-term consequences which might be avoided. Gastric banding, it is still a procedure which, if one would look at it objectively, would give a very good result to about, I would say, 60 to potentially 70% of patients undergoing gastric banding. But we know that over time, about 40% of patients would need revisional surgery to either reposition the band or to remove the band and to replace it with another procedure. It's potentially beneficial in the sense that one would not be removing any parts of the gastrointestinal tract, such as with a sleeve gastrectomy. And in the event of future medication become available which would be as effective as surgery, then at least one could argue that one hasn't lost any part of your anatomy. However, it's not fully reversible. It's removable, but some of the patients who develop complications from gastric banding probably would still bear the scars, you know, to show for it down the track. A new medical device which has become available and which has huge promise is the endobarrier. Now, essentially, with the endobarrier, and potentially this doesn't show it that clearly in the diagram, it essentially involves a sleeve of impermeable material which is inserted into the top section of the bowel. What essentially happens is that it seals the bowel off at the top end so that food would travel on the inside, and that bile and digestive pancreatic juices would travel along the outside, and then the two would only mix around here. The distance to that point is about 60 centimeters, and that is just enough for significant hormonal changes to take place in the body, so that absorption and digestion is changed, and also the way that the body then uses the calories which gets absorbed. It is a very new procedure. There is not a Medicare rebate for it as such at present, and the health funds also do not have a rebate for it. But it is something that could change in the future. Another procedure is insertion of a balloon in the stomach, an intragastric balloon, which needs to be removed about 6 months down the track. It helps patients to actually kickstart any weight loss program. It could also be a bridge to surgery, but the important thing is that it needs to be removed. This is covered by Medicare and by the health funds. Just something about the endo barrier is that it also needs to be removed after 12 months. And even though these devices get removed, there's a so-called legacy effect. So the benefits last beyond the duration of having the device inside.
Good evening and welcome. Thank you for the opportunity to talk to you tonight about your dietary management associated with bariatric surgery. Both myself and Sarah have been working with Dr. Jordaan for some time now, and I must say that it is actually wonderful to see the transformation that people go through, both men and women, when they get to the other side, post-surgery recovery, and they start to see themselves in a new light, and it's really quite magical. It's almost like a glass of champagne and the bubbles coming out the top. It's really quite a wonderful experience to be involved so intimately in someone learning how to eat again, and learning the value of investing in themselves, and learning the value they get back in their life. And I know Sarah and we really enjoy that part of our role in seeing that transformation of people. When we think about what does bariatric surgery do for you, it sets you up for success with weight loss. Your surgery provides you with a tool, and with team support from Lorraine and the whole team, Sarah and myself, you learn to have a different relationship with yourself and food. So it sets you up to be successful. And it's a wonderful thing to know that you actually can eat less food and feel satisfied, and not have to be burdened by the thought of always going, oh my God, I wish I could eat less. And it's a really liberating feeling, and people feel wonderfully better by not having to have that worry, that ongoing worry about how do I stop eating. The key to long-term success with bariatric surgery is to relearn how to eat, and Maddie touched on a lot of those things about new relationships with food and how to eat. And sometimes that's challenging, but you do get there in the end. And one of the things that's very motivating is you actually see yourself in a new light, and you're much smaller. I had one gentleman come in to me and say, he said, I think my clothes are stretching, because he couldn't actually believe how much weight he'd lost. And when I weighed him and measured him, he just had this grin about this big. He was so delighted in the progress that he'd made. So when we look at dietary management associated with surgery, there's 3 stages. One is the preparation for surgery, which is about making sure that your liver size is small enough to give you optimum viewing so you can undertake the surgery. The second stage is post-surgery, and Maddie talked about that being challenging. And we see it as a great opportunity for you to become not only physically aware, but mentally aware of what you're eating with your food, and having that initial phase where you go from fluid back to normal texture provides you with an opportunity to get in touch with what it feels like to eat less. And it is a role of learning again and taking the time to eat slowly. And if we put those steps in place, what we have at the end is really wonderful, because it's almost effortless. And then stage 3 is about really enjoying, as Maddie said, that wonder of actually being able to go out and eat and go, well, I'm done. And there's not that regret about, gee, I wish I could eat more. So it's a really empowering type of new behaviour, new relationship with food. The things that we learn and that are supported through the journey when we look at stage 2, which is post-surgery, is the journey of that texture upgrade. And this is where there's a great opportunity to become aware of what it means to have a small mouthful of food, to chew slowly, to take your time, to pace your eating. All of that is, you know, people go, well, I've got to get through that post-surgery phase and then it'll all be better. That's a really valuable time to learn and really cement those new behaviours and that new awareness. We also work with you to develop menu plans so that the structure of your meals is adequate, because one of the key roles we have is, while you're losing your body fat, is to sustain as much as possible your muscle mass, because that's the key that keeps your metabolic rate at a high level. We work with you to develop menu plans and establish a healthy eating pattern that fits with your lifestyle. And at the end, you see this person who is independent like Maddie just having a wow of a time in her new body. The other thing that's important, and Lorraine will discuss this with you, is also the mindfulness about you have about yourself, about your new body, and about your relationship with food and how it tastes, how much volume you're eating, and how you're eating, the pace of your eating, and also that sensory awareness of what food tastes like. Maddie talked about nutritional supplements, and we usually, there's always a nutritional screening done at the start, prior to your surgery, and we generally start your supplementation usually in the pureed phase, but that's not always the case. And Sarah and I will both assess what happens, what you're managing with your dietary intake, and what's appropriate. The key supplements are usually a multivitamin, multimineral, vitamin D, B12, vitamin A, calcium and iron. And that's very much, we tailor that based on what you require, because not everyone requires exactly the same. The key things as we develop you through that process of recovery, we come back to more normal textured and normal eating, is we establish a regular eating pattern. Because the volume of food that you can eat is smaller, we need to have a regular pattern to ensure that we get the optimum amount of food intake to have a nutritionally adequate intake. And again, we look at development of mindfulness and sensory awareness about food behaviour. Oh. One thing I'd just like to add is that one of the wonderful things I've seen is that this surgery provides people with an opportunity to have that ongoing motivation to invest in themselves like nothing else I've seen. It's really quite, has a really positive effect on us, because it sees people transform and to become their real true self. So I really appreciate having the opportunity to work with such a wonderful team. Thank you.
Hi guys, thank you for allowing me to talk to you about psychology. I always get why psychology, so I thought we might just look at what psychology is all about and why we encourage you to come and see a psychologist and go for assessment. So the goal of psychology is not to be the gatekeeper, but actually to learn about what patients' needs are. The work and effort of bariatric patients is one of the hardest work that any patient will go through. It's quite a heavy journey, and the team supports you through that journey. So surgery is stressful for anybody, but we want to make sure that you are ready for the challenge physically and emotionally. So psychology is about the early identification of problems. It's not about denying or delaying people. It's about trying to identify what are going to be the obstacles that are going to get in the way of you achieving your health goals. So why assessment? Well, assessment provides us information that sometimes is not accessible within an interview. So when you come to see me as a psychologist, we will do an interview, and then I'll probably ask you to complete a few questionnaires. So psychological assessment allows us for a much larger breadth of understanding that things that you might not know about yourself, and then I give you that feedback. psychological assessment is a widely utilised and acceptable part of a multidisciplinary team. And it can help identify your strengths and areas where you may need additional support in order to help you achieve and maintain your goals. The assessment is to assist the team to better understand your motivation, and it's important to identify the clinical significant psychological symptoms that could affect your response to surgery and your ability to recover from surgery. So it includes that one hour face-to-face interview and the completion of questionnaires which take about 10 minutes at the end of the interview. These are the areas that it covers. So it looks at your lifestyle, your sleep, exercise, smoking, drinking behaviours. It also looks at any psychological issues that you've had, whether you're seeing a psychologist, when you see me, whether you've suffered from depression or anxiety. We have a look at those things, but they're not barriers. So assesses your ability to cope with stress, any stressors that you may be having. Really importantly, what your social support is like. Any psychological issue that may affect your surgical outcomes, so something like eating-related problems, concerns about surgery and lifestyle changes. So I will talk to you about your results and we'll go through all of that, work with you to develop any strategies that you may need. I really encourage you to stay close to the team and be supported by the team. Sometimes I find patients come and we do the assessment, they have the surgery and then they disappear. It's a difficult journey, and this team is there to support you to reach those goals. And just one final thought, given the marked weight losses occurring in the period immediately following surgery, longer-term weight loss maintenance requires you to adhere to post-operative behavioural recommendations. So changing things, being able to make those changes, whether it be exercise, lifestyle, eating quality, not quantity. So they're the things that we look at when we're doing psychological assessment. And thank you.